It's early to give these gentlemen a few more minutes with the meat and potatoes that is being served today. Good morning and welcome back to day 2 of the International Concussion Summit, Prevention, Diagnosis, and Treatment. If you thought yesterday was good, you should buckle your seatbelts today because today is going to be a tremendous day. We have 3 extremely talented speakers coming with you this morning. This summit is also being streamed live for those that couldn't make it, so if you want to text somebody back at home that it is being streamed live, the link can be found on the ICS webpage. All sessions are also being videotaped and will be made available for viewing after the summit. I was also asked about the doctor's slides and notes. They also have generously said that we could use them. They'll be posted on the webpage as well. We likely need a week or so to get them up and running, but if you check back in a week, all those slides that you saw yesterday as well as today will be on that webpage. If you're tweeting, the hashtag for our conference is hashtag ICS Niagara. It can also be found in the back of your programs. There'll be a short question and answer period after Dr. Delaney speaks. So Dr. Cantu will speak first, then Dr. Delaney, then we'll open up for questions for both of those doctors. Now it's my pleasure and my privilege to welcome the keynote speaker for today is Dr. Robert Cantu, the one and only Dr. Robert Cantu, I should say. Dr. Cantu is the clinical professor of the Department of Neurology and Neurosurgery at the Clinic Diagnostic and Therapeutic Leader AD and CT Center at the Boston University of Medicine, as well as medical director and director of clinical research, Dr. Robert C. Cantu Concussion Center at Emerson Hospital. Dr. Cantu serves as senior advisory to the NFL Head, Neck, and Spine Committee. He's also founding member of the medical director of the Concussion Legacy Foundation that some of you had heard about from previous concussion summits here. Dr. Cantu chairs the Scientific Advisory Committee, National Operation Committee on Standards and Athletic Equipment. He's also a consultant on numerous NFL, NHL, and NBA teams. Please join me in welcoming Dr. Cantu to the podium.
Thank you very much for that so serious introduction. It's a pleasure to be here. Some disclosures, but no conflicts, hopefully. We're going to talk a little bit about concussion and a little bit about the history of concussions, some of the things that we hope we've learned over the last 50 years dealing with it, and then go off into CTE for kind of the second half of our presentation and where we think we are with it in essentially 2018. Concussions have been known for a long time. Descriptions of brain injury consistent with concussion go back as far as the 10th century. Most concussions before the 1970s were thought of as involving loss of consciousness, and since then it has been less so. In fact, a very small percentage actually now of diagnosed concussions involve loss of consciousness, less than 10%. The various different theories of what is going on with a concussion involved a vascular theory where we thought it was ischemia or spasm of blood vessels that caused symptoms in the parts of the brain where blood flow was not adequate. When loss of consciousness was a big deal with concussion, there was the ascending reticular activating system theory of concussion. This is a fiber tract system that goes from the top of C1 in the spinal cord up to the thalamus in the center of the brain. And it was thought concussions impaired that particular system, and indeed, when there's loss of consciousness, that's true, but since that doesn't account for most concussions, that particular theory's fallen largely by the wayside, and the one that survived of all of them that have been out there through the years is the centripetal theory of concussion. And this is a theory put forward by Generali and Omaya, two neurosurgeons back in the 60s, using primarily research on primates, in which they stressed that there were stresses and strains that were put on brain tissue primarily as a result of linear, but more so rotational accelerations of brain tissue. With every blow to the head, or whether it's direct or indirect, there are both linear and rotational forces imparted, and they felt it was the rotational that had a greater effect. And I think that theory is the one that stood up the best and the one that we're still working with largely today. I think, as others may have said, the brain is the consistency of jello or custard. It's solid, but it's certainly easily moved. And these linear and rotational accelerations do just that. They violently move the brain and stress and stretch the nerve fibers and the nerve cells. And in the process of doing so, depending upon where the maximal stresses and strains are, a variety of symptoms can occur depending upon what area of the brain is involved. And most of us think of these symptoms as being in buckets or groupings: cognitive symptoms, physical symptoms, emotional symptoms, sleep symptoms. So that those of us that work in concussion centers today, and those of us that see post-concussion syndrome patients, which is really just a persistence of concussion symptoms beyond a month, is what most of us use, but there are other definitions that can be used. And roughly 20 to 30% of concussed individuals won't have their symptoms clear up within the first 10 days to 2 weeks for adults, or first month for kids, and will go on to this post-concussion syndrome. So that those of us in concussion centers now very often use what we refer to as checklists, and in our case, we like to use a checklist that has the groupings into cognitive and balance and coordination and sleep domains, so that when we see an individual, every time we can quickly get an idea of how they're doing from their checklist score based on the number of symptoms they have and the severity of those symptoms. In diagnosing a concussion, I think it's important to use a comprehensive neurologic exam in addition to the symptom checklist. And then there are certain parts of the neurologic exam that really, at least in our opinion, have been most useful in concussed patients. It's rare for reflexes to be off with a concussion. It's rare for there to be weakness in limbs. But it's very common that balance is impaired, and it's very common that eye tracking is impaired. So those particular areas of the neurologic exam are focused on more so than perhaps other areas in seeing individuals, not so much the first time, but in follow-up. And so the takeaway message number one that we'd like to put out there is that we believe that the more tools you use to diagnose a concussion, the more accurate you're going to be. There is no one tool that allows us to be certain that a concussion has happened, except if the individual has had loss of consciousness. It's interesting for me to think back that in the 1870s, people were writing about the structural nature of concussion. We're all very well aware of the neurometabolic cascade that's so beautifully been shown in the rodent animal models by Dave Havda and his disciple Chris Giza, but not so much has been thought of until very recently about the structural nature of the injury of concussion, unless we think, and we go back to writings, among others, James Christian Brown, who really was putting forward that concussion is a structural injury as far back as 1871. Concussion really consists of what may be called dynamic changes in nerve cells and their connecting fibrils. And another person that pretty much was writing about the same thing, these authors all were in the 1920s, in and around the Harrison-Martland era. But Mott talked about repetitive head trauma producing structural changes and a number of neuropathologists, among them Casa, Osnato, and Vincent Gilberti, and Harrison Martland himself, talked about the concussion hemorrhages, the microhemorrhage that they saw with concussive injury. So maybe takeaway message number 2 might be that concussion is a neurometabolic physiologic injury, and in some individuals, as best we can tell, it may be just that. But in a number of instances, many more than we probably can recognize by today's technology, because it's microscopic level that's being injured, it's also a structural injury. A structural injury in some cases of nerve cells, but more commonly of their connections, the nerve fibers themselves. It's also interesting for me to think that concussion isn't really just a recent thing in clinical medicine. People that took care of industrial individuals at high risk for brain injury, and probably the greatest numbers were in the railroad industry in its earliest days. And so there were texts by people, in this case Dr. Walker, who stated that concussions were common enough that mental impairment of post-traumatic origin is surely well known to every practitioner in industrial districts, meaning doing industrial medicine. And he was really talking primarily about seeing those that worked on the railroad. And that was written about in the 1930s, and so concussion really was known in clinical medicine then, but certainly kind of fell out of the consciousness until more recently. So concussion, maybe the third message or the third takeaway message, is that the majority of concussions fortunately clear up quite rapidly. In most individuals, maybe as high as 70 to 80%, depending upon how closely you look, within 10 days to 2 weeks in adults, and within 3 to 4 weeks within youngsters who recover a little slower. But another group goes on to more persistent symptoms, and a very small percentage will go on to permanent post-concussion syndrome symptoms, the exact number of which is not known, but it's probably not more than a few percent. This is another concept that came to the consciousness of many people around 2000, but was really known well before that. These are animal studies by Tedeschi. They were done at Boston City Hospital, which is the main hospital, flagship hospital for Boston University. These were studies that were published in the mid-40s, and they were looking at animals where you had their head fixed and something hit them, versus their head not being fixed and something hitting them, but now their head could move as a result of being hit. And they found that if you fixed the head, there was significantly less loss of consciousness, and there was significantly less chance of death in these animals. So fixation of the head decreases your chance for having a concussion, decreases your chance for having a serious brain injury. And this is an example. I guess you're going to have to start it. There it goes. Could we repeat that, just because at least it caught me by, if it's easy to just all right, that's the very famous Dale Earnhardt crash, 2001, Daytona 500, last lap. He's blocking for Darrell Waltrip, who would win, Michael Waltrip, Darrell's brother, who would win that race. Dale got tapped in the rear and slid up the track and T-boned the wall with what didn't look like a terribly serious crash at the time it happened, except that it did cost him his life. He had loosened seat belts in his car. He didn't have a head and neck restraint, which was pretty common in those days. But when his car T-boned the wall, his head was thrown forward with such force, with the weight of the helmet on top of it, that the ligaments at the top of the cervical spine could not keep his head connected to the cervical spine. So he suffered an atlantoaxial dislocation, which proved to be fatal for him, as it did for 3 other NASCAR drivers that same year. So with this rash of deaths, and certainly the most famous of them all in the sport dying of that injury, and there being a mechanism to prevent it, meaning restraining the head, the Hans device was declared mandatory for NASCAR drivers, and there's never been a death since due to that mechanism. And to show you just how effective restraining the head can be, this is a Indianapolis 500 race this past May, 1 year ago this month, in which Dixon is going to be rendered airborne. You're going to have to start the video because this isn't working from here. Oh, there it is. Sorry. You'll watch him become airborne. He hits the inside wall. The car shatters apart. It's made to do that, to dissipate energy. Look that his hands are off the steering wheel. They're taught not to hold on to it for obvious reasons. And he climbs out. Obviously, if his car had impacted the wall about 3 feet further forward where he is sitting, it wouldn't be the same story. But with his head and neck and body completely restrained, the gyrations of the car itself did not even produce a concussion. So maybe takeaway message number 4 might be concussion risk is reduced by decreasing the rapid movement of the head, such as with a head restraint in automobile racing, or what we have on athletic fields, our best restraint for the rapid movement of the head from a hit would be a very strong neck who saw the hit coming. So if an individual did brace for a hit, the chance for concussion could be reduced. And although helmets have had great improvement through the years, and Blaine has played a significant role in that, and all of that is perfectly wonderful, they'll probably never be the total solution because they won't prevent the head from quickly being moved when the masses are so great of these individuals and the speeds which they're closing at. Another thing that's burst onto the public awareness in the last 4 or 5 years is this whole concept of subconcussive trauma, that you can have repetitive injury to the brain, damage to the brain from multiple hits, any one of which alone would not have produced injury. And especially that's true when these hits are in very close proximity. Well, that's a concept that's been shown on athletic fields today using today's technology, magnetic resonance imaging, DTI looking at fiber tracks, functional MRI looking at metabolic studies of the brain, PET scans doing the same thing, and to a certain extent functional testing as well. But that concept was demonstrated in animals way back again in the 1940s by Tedeschi at Boston City Hospital, in which he looked at a group of animals, subjected them to subconcussive trauma, and found that when repeated subconcussive blows were delivered in a short period of time, there was a higher incidence of long-lasting effects on the animal than when they were delivered days apart. My interest in athletic concussion, being a neurosurgeon, obviously I was taking care of concussions from the get-go in the 60s when we started. But my interest in athletic concussions happened in 1970 and in the years thereafter when we moved our family from Boston and to the suburbs. At that time I was attending at Mass General, and decided that with young kids we wanted to be out of town, and so we moved into the suburbs, and local high schools enlisted me to be a football physician on game day for their games. And obviously one of the things we had to take care of were concussions. There were not concussion guidelines back at that time, and so we looked at the world's literature and came up with what we thought were reasonable guidelines for returning individuals to after a concussion to a collision sport. And you might note that we were, at that time, back in the 70s, wanting these individuals to be asymptomatic at rest and exertion before we allowed them to go back, something that would take a number of years to kind of catch on. And back with that paper, we also had a concussion severity scale that we put forward, and we were using for the intermediate group of concussion individuals with a loss of consciousness of less than 5 minutes versus the severe group, loss of consciousness greater than 5 minutes. And then as years went by, we realized, wait a minute, we're not seeing loss of consciousness greater than 5 minutes almost never on athletic fields. So we came up with a more rational scale in 2001 in which the 5 minutes became 1 minute. And even with that scale, the numbers of individuals that wound up with grade 3 concussions, 98% got into that category because of the persistence of symptoms greater than 7 days, not because of loss of consciousness greater than 1 minute. So loss of consciousness is not only uncommon on athletic fields, but when it does occur, it almost always is only for seconds. So the question's out there: are we seeing more concussions today? Well, certainly more are being reported, and I think we are seeing more concussions today, partly related to the fact that athletes are bigger, stronger, faster than they've ever been and hit with greater force than ever before, although the helmets admittedly are better than ever before. There's no question that we're diagnosing concussions better, and there's no question that athletes are beginning to start to report their own symptoms. But I think one of the other reasons that needs to be floated is that our definition of concussion has gotten to be a bit more broad and is a bit more focused now on the symptoms of concussion, which can be produced at lesser forces than the loss of consciousness. Back in the 70s, when loss of consciousness had to occur roughly 6,000 radians per second squared for average situation with that, produce some symptoms of dizziness, lightheadedness, sensitivity to light noise. Much less acceleration probably needs to be imparted to the brain in most of those cases. I think this is probably, of all of the takeaway things that we'll try to talk about with regard to concussion and with regard to CTE, this is the one that I'm probably most passionate about. There's a strong tendency to talk about the number of concussions somebody has had. And while I don't think that's insignificant, it's the least important thing in my mind about the major issues with concussion. And there are many professional athletes that we've seen, which if you use symptoms imparted traumatically, that have had more than 50 concussions and have gone through their careers just fine. I'm not suggesting people do that, but I'm just simply saying that has been incurred by a lot of people. So I think that what's much more important to me than just an absolute number of concussions, though we do think about it, especially in our scholar athletes, it's how close the concussions were together. It's a little more important to me because 2 or 3 in 1 year is a much bigger deal than 2 or 3 over 10 years. But by far and away the most important thing to me is how long the symptoms lasted. So somebody that has symptoms that go on to post-concussion syndrome and last 6 months to a year, that's not the same brain injury as somebody who had symptoms that lasted a day or two and then cleared up. So I don't think you can just look at numbers of concussions. It's really important to know the severity of the concussions, and to me that plays a big role in who we suggest may or may not go back to play, as does also the severity of the blow that caused the concussion, because a horrendous blow resulting in a concussion could be expected. A light impact, indirect, snappy to the head a little bit, not so much. So if somebody's being concussed now from things that never would have concussed them before, in most instances, I think that's probably time for people to stop. Another area of concussion that I think has changed dramatically over the last 50 years, and this is something that is probably mostly in the last 10 years and gained real big momentum in the last 5. This was a meeting that was put together by Mickey Collins and Anthony Cantu in Okinawa at University of Pittsburgh. 38 people from across the country came to that meeting from various backgrounds, from researchers to clinicians, neuropsychologists to neurosurgeons, quite a mixture, and we went through a number of different issues with regard to concussion. And out of it came a publication in neurosurgery. But I think the big message of that meeting and of that paper is that concussions are treatable. And indeed, at our center, we have physical therapists that are involved with exercise therapy for concussion patients. We have cervicogenic certified physical therapists that treat neck and cervicogenic symptoms. We have ocular therapists, occupational therapists that have ocular subspecialty training to treat the eye tracking difficulties. We have people that treat the vestibular difficulties, also physical therapists. We have speech and language pathologists that do the cognitive assessment and return to school assessments. And then if that needs to be beefed up, we have 3 neuropsychologists that can do more formal training in that area. So concussion was pretty much, for a long time, treated by just rest. And it is true that short-term rest, I think, is important, maybe for 24 or 48 hours, depending upon the severity of the concussion, longer if symptoms are numerous and severity is high. But then active treatments are normally instituted by most of us in the field today within the first few weeks, were those that have persistent symptoms. So takeaway message number 6 might be concussions are treatable with therapies, which would be my first choice. And then if therapies don't work, there's pharmacy that can back up and augment and alone continue to treat. I'm going to shift gears for the last half of the talk, and we'll get into CTE and kind of where we are today. My beginnings with that started in the late 90s when I wrote a book called Boxing and Medicine. And we did the chapter, among others, on CTE, and that got me reading the world's literature on that particular topic, and I was rather amazed at how much there was. More recently, Bennett Amalu discovered CTE in Mike Webster and published it in Neurology. He did not found the disease, as his book and the movie talk about. He found CTE in a National Football League football player. And actually, it was a great coup on his part. He was on duty one Sunday and had this homeless, living in his car, former National Football League player come into Allegheny's morgue to have an autopsy done. And he wondered why this guy was cognitively and emotionally impaired at such a young age, in 50s. And he had the wisdom. He didn't have the facilities himself to do the histochemical staining for tau, phosphorylated tau. So he enlisted Dukoski, a neuropathologist with experience in Alzheimer's disease at University of Pittsburgh. The brain was studied. The brain had CTE. Cat out of the bag. First National Football League player with CTE. Second was Andre Waters, a defensive back who led with his head and had a lot of concussions and a lot of subconcussive trauma. The real story of CTE, though, I don't know whether you can hear this.
Case death.
Well, it's not important that we heard it. That's
Repeated
Harrison.
sharp blows
That's
may well result in serious mental or physical injury, or even, as is too often the case, death.
That's Harrison Martland, who is a neuropathologist who wrote in 1928 in Journal of American Medical Association the story of Punch Drunk in terms of what he had found in boxers. And he found boxers that basically were sluggers that took a lot of blows, boxers that had boxed for a long period of time, boxers that did an inordinate amount of sparring in the gym between fights, had a greater chance for behavioral, cognitive, mood, and motor symptoms, bradykinesia, Parkinsonian-like neurologic symptom pattern. And this is a famous right hand of Rocky Marciano hitting Ezzard Charles. In boxing, we see greater motor problems than we do in our football players, and we think that's because there are more rotational accelerations of the head violently in boxing than in football, twisting the brain and brain stem. In football players, it's mostly, though not at all, only, but mostly using the top of your head and the front of your head for more linear, straight ahead type of blows. The real story of the description of chronic traumatic encephalopathy was by this English gentleman, Critchley, who in 1949 wrote in a book in honoring the death of the French neurosurgeon Claude Vincent, who had trained in the United States under Cushing, described what he called chronic traumatic encephalopathy, and then he would write in 1957 in the British Journal of Sports Medicine more or less the same chapter, in this case in a peer-reviewed paper. So chronic traumatic encephalopathy really came from McDonald Critchley in terms of the name of it. But once again, let's think back. We're talking about 2002, Bennett Amalu finding CTE in Mike Webster's brain. Back in the 1930s, there were reports of punch-drunk football players. They called them stumblebacks. And the symptom presentations were essentially similar to the behavioral and cognitive mood issues that we see with CTE today. This was a magazine equivalent to Life magazine back in the 30s, talking about punch-drunk football stars. This is a article from the Milwaukee Journal, 1937. Why do halfbacks become half-wits? I won't go on, but the point is, there had been some concern raised a long time ago about repetitive head trauma and maybe some later life problems. And yet, it kind of fell out of the consciousness. Well, I put this up here because we can't let leagues stop us from trying to put forward science, and science will win out ultimately.
In cases of CTE, there is often damage to the frontal lobe. That's the part of the brain responsible for impulse control and decision-making.
So, Dr. Sofer, let us assume that Jake Standen has CTE, this dementia you're speaking about.
Objection. He cannot ask the jury to assume what...
I'm going to cut that short in the interest of time. Unfortunately, a lot of good has come about from the press and the TV and the media picking up The work that Michael Schwartz and others have done in the New York Times, and now even TV picking up and dramatizing cases of CTE, which are pretty accurate for the most part because of the medical backup that they used in them. But there is a little bit of hysteria about it, and that's unfortunate. The media and the attention is on one tangent, and the science is slowly trudging forward. Not nearly as dramatically as the media, and so I think it's important to kind of make a connect with regard to where we are today. In 2008, Chris Nowinski, the founder or co-founder with myself, I guess, of then Sports Legacy Institute, now Concussion Legacy Foundation, needed a brain bank. We needed a brain bank to study brains. We had been with Bennett for a couple, and then we decided that that probably wasn't the way we wanted to go with the rest of the work we wanted to do. And so we looked and found, right in Boston, where we both are, Dr. Ann McKee, who was, at that time, an expert in hyperphosphorylated tau degenerative neuropathies, meaning Alzheimer's disease, Lewy bodies disease, Niemann-Pick's disease, frontotemporal lobe dementia, but not so much CTE at that point, because that kind of wasn't on anybody's radar. But we founded with Boston University in 2008 the first center to be dedicated to CTE research, pathological clinic, and basic science. And now that number of brains is well over 500 and well over 350 confirmed cases, as this slide is about a year old. That's the team that was assembled. Chris, he got the brains, former Harvard football player, former WWE wrestler, and now, as of last year, Dr. Chris Nowinski, having obtained his PhD at Boston University. Ann McKee, recently noted as one of the most 100 influential people in the world, according to Time magazine, for her wonderful research, neuropathological research on CTE. Bob Stern directs the clinical studies, and we kind of tag along with him and give him a lot of ideas, I hope, that allow me to do not a lot of heavy lifting, but partake in an awful lot of thrilling scientific work. And then more recently, the animal research is Lee Goldstein, and I'll nearly end this talk with a very interesting paper that was recently published by Lee. So there are several things going on. We've got the brain bank, that's what you've probably heard most about. We have longitudinal clinical studies. We're going to show you some of them. There are now over 45 papers that have come out of this neuropathological and clinical work. And we also have the preclinical work of Lee Goldstein with a couple salient publications. This was the first publication put out in 2009, 1 year after the center opened, and in it Ann summarized the world's literature with CTE and added a couple new cases that we had at that time, including Paul Pender, a former middleweight champion who had gone to school in Brookline, a Boston suburb, and had been a professional boxer from his high school career years through his mid-30s, and when he was in his 50s, was institutionalized in the VA hospital system with dementia. When he died, his brain showed dramatic CTE, and this is one of the pictures from a second publication in 2013 in which 68 additional cases of CTE were published. The brownish deposits are the phosphorylated tau, the abnormal tau that is the hallmark of CTE, but is only a tiny part of the total disease, because the disease itself involves breakdown of the blood-brain barrier, inflammatory responses with microglia. It involves axonopathy, tearing apart of axons, things, though, that can't be easily measured. What can be easily seen, relatively, are these deposits. And when they're at depths of sulci around blood vessels in a patchy distribution in the superficial layers of the cortex, that's the hallmark for CTE. And I'll show you that again in a minute. And in that 2013 publication, Ann also put forward a classification scale for stages of CTE. Stage 1, 1 or 2 little deposits around a blood vessel, no more that you can find. If you find more than 3, you're in stage 2 disease. This is still all cortical. By the time you get to stage 3, it's not only the cortex involved, but the medial temporal lobe is involved, and you start to get deeper structures in the brainstem as well. And stage 4 disease has most of the brain involved. All stage 3 and 4 disease individuals are symptomatic. Not all in stage 1 and stage 2 are symptomatic. There are most stage 1 disease is not symptomatic, some even stage 2 is not symptomatic as far as we can tell. So through the years, there have been some criticisms about CTE, whether it is distinguishable from other situations where you're going to find tau deposit, phosphorylated tau, deposited in the brain. CTE is distinguishable, distinctly different, is not what you see with aging, and it's not what you see with Alzheimer's disease. This is an international consensus group called together in 2015, funded by the NIH, and subsequently published in 2016, the criteria that needed to be there for CTE. The pathognomonic of CTE are these hyperphosphorylated tau deposits around blood vessels at the depth of sulci. So here we have them at the depths of sulci. They're around blood vessels, and they're in the superficial layers of the cortex. That's the pathognomonic lesion of CTE. So many so-called cases of CTE may or may not honestly pass this criteria. There are a lot of other things, other deposits of tau, hyperphosphorylated tau, that may be there that support CTE, but in and of themselves do not make the diagnosis of CTE. And there are other areas of the brain where there can be deposits of tau that are totally irrelevant to whether or not it's CTE or not even supportive of CTE. So some questions. What are the clinical presentation and course of CTE? Can it be detected and diagnosed during life? And how can CTE be treated? Well, first of all, right now we can treat the symptoms of CTE with largely the same therapies and pharmacies that we use for post-concussion syndrome and or Alzheimer's disease, but we can't treat the underlying tauopathy as of today. Today we can have a high index, and we'll get into why, that CTE may be present, but we cannot diagnose it with certainty with anyone who is still alive. The clinical presentation of CTE involves cognitive issues in the beginning, recent memory problems, getting into executive function as it becomes more severe, with difficulties with insight, judgment. It involves mood issues with depression, anxiety, panic attacks. It involves behavioral issues, predominantly impulsivity and explosive behavior. But there's too much overlap in the clinical symptomatology with other neurodegenerative diseases, like Alzheimer's disease, like frontotemporal lobe dementia, to make the diagnosis clinically with absolute certainty. Requires neuropathological diagnosis to be absolutely certain. A couple years ago, there was a study out of UCLA that suggested there may be a tau ligand that would allow you to diagnose CTE in a living individual, but The sample size was very small. I don't know how it got published with 5. And FDT, and more importantly, this compound had been around, this PET ligand had been around for over 15 years, being used in Alzheimer's disease, and it bound to amyloid, it bound to tau, and it didn't bind to tau just specifically in CTE. So there was no way of discerning whether you're really dealing with CTE or one of the other neurodegenerative diseases. There is a ligand that binds only to hyperphosphorylated tau. It's fluorobeta-pure, and that is a compound that's being used both at BU for a number of years and other places. Sam Gandy's published several papers with it. The problem is, I said that the neuropathologic diagnosis with CTE was depths of sulci. You could see the smudges that occur with this if they were close to where you would think the depths of a sulci might be. But I also said they were perivascular. That's a microscopic diagnosis. So using a macroscopic imaging to look at a microscopic problem, you're not going to be sure it's really around blood vessels. And that's the big problem in my mind with fluorobeta-pure. Not that we shouldn't keep the research going and all that is fine. And Sam's kind enough to keep me in some of it, but the point is, I don't think that's ever going to be the magic bullet unless the resolution of being able to see it gets down to the microscopic level, or at least gets a lot better than it is right now. Right now, it's a kind of a smudgy thing that you can get a pretty good idea if it's where the depths of a sulci should be, but that's about it. And there are other publications. This is Anne and one of her doctoral students who came up with a protein, CCL11, that shows some promise as being specific for CTE, but it's going to take a lot more work and a lot more people in which it's been studied while they're alive, and then when they die, they are proven to have CTE before we really know the efficacy of that. So, aging is not CTE. Anybody who wants to claim that it's out there in people just because they're old, I think that's quite inaccurate. It is not in the areas of the brain where it is needed to be called CTE. We see, obviously, deposits of hyperphosphorylated tau with Alzheimer's disease. Once again, it's not in the areas where it would be with, it is not in the depths of sulci, and with Alzheimer's disease, it's predominantly in the 5th and 6th layers of the cortex. It's not around blood vessels, so it's easily distinguishable from CTE. Also in Alzheimer's disease, there's usually beta amyloid present, which also makes distinguishing easy, although there are some cases of CTE where, although beta amyloid is not predominant, it still is present. CTE, about 50% of the time, is seen with another neurodegenerative disease, like Alzheimer's disease, and about 50% of the time, in our experience, is unique. That's pure CTE. But so are other neurodegenerative diseases, often seen together, about 50% of the time. It tends to go with the nature of the disease. The fact that CTE cannot be diagnosed during life and therefore is not a distinct neurodegeneration, I think, holds no merit, because neither can with absolute certainty frontotemporal lobe dementia or Lewy body dementia. These are neuropathological diagnoses of those neurodegenerative diseases that can only be made with certainty after they're dead. So being a neurodegenerative disease, that's not surprising. The fact that we are publishing many cases from observational science, meaning that brains are submitted and we look at the brains and we report the brains, that's the best we have at this particular point in time. Obviously, we can't carry out on human beings the kind of head trauma research that would be necessary to prove cause and effect, although I will show you an animal study shortly that has allowed us to do that in animals. What we know about CTE is it is a progressive neurodegenerative disease, probably in most cases, maybe not in all, and I say maybe not in all because we have individuals as old as 81 with stage 2 disease, and it's hard to believe that trauma taken in your 20s only got to stage 2 if it truly was progressive. So there's hope it's not progressive in everyone. It is not post-concussion syndrome. In almost every instance, there's a gap of years from when the head trauma occurred to when the symptoms start to occur. Although there are a few cases which we published that went right from post-concussion syndrome to suicide, and when their brains were looked at, they had CTE. And most importantly, it is not just the result of concussions. About 20% of our cases have no recognized concussion. Whether it was unrecognized in there, we don't really know, but the point is we now have animal work that backs up that you don't have to have concussions to have CTE. The risk factors for CTE are repetitive brain trauma. It's present in almost every case, but it also requires something more than that because we know that not everybody with repetitive brain trauma is going to wind up with CTE. So it's a little bit like cigarette smoking and lung cancer. Not everybody that smokes will get lung cancer. Not everybody that takes repetitive head trauma will get CTE. There are obviously other genetic, possibly environmental, possibly nutritional risk factors that we're looking for and have been since 2008, but as yet have not really diagnosed them. With regard to the fact that we cannot diagnose it as a clinical symptom based on clinical symptoms alone, I think is not a reason to not think it's a real entity. That's largely true for other neurodegenerative disease processes in the same family. The clinical presentation of CTE, the classical presentation, is somebody plays sports or gets shot out of a cannon or gets assaulted frequently for a certain number of years, then it stops, they finish school, whatever. They go on to 10 or 20 years of no symptoms and then start to pick up cognitive issues, primarily short-term memory issues that go on to executive function. And along the line, a few years later, they start to become more impulsive. And along the line, they may have anxiety and they may have depression. And those are the hallmarks of the classical presentation of CTE. There is a non-classical presentation that doesn't occur in your 40s and 50s as that does, but rather occurs in late 20s and 30s in which there isn't a cognitive component. It's basically just behavior and mood. It's impulsivity, violent behavior, short fuse, out of control behavior, depression, anxiety, panic attacks, and those are the people that brains wind up being studied tragically because of suicide. It has been identified in individuals as young as 18. This is Eric Pelly's brain. That's the focus of CTE. It involves a breakdown of the blood-brain barrier. It involves neuroinflammation. It involves neurodegeneration. It involves neural loss. And probably it's because of that axonal disruption that somebody with just a spot or two of this in their brain, which is not enough total brain to ever be expected to produce symptoms, may have symptoms because at the microscopic level there's been enough axonopathy that has already occurred, even though there's not much tau. Almost every case of CTE in the world's literature has had a history of repetitive brain trauma. There's one case, very famous from Canada, where such brain trauma is not known, but the individual was an adult when he married his wife, and his early years are not known, so we really don't know well what went on early in life. This is a picture of where we normally see microvascular injury in traumatic brain injury, depths of sulci, because the stresses and strains are greater there. And that's exactly where we see this deposition of hyperphosphorylated tau around blood vessels, and it's probably related to mechanical factors. This is just a list of some of the studies that have been published recently, not even a current list, putting forward the importance of subconcussive trauma and how subconcussive issues, I'm fighting the clock here, I've got 7 minutes, I'm going to try to make it, how these subconcussive issues are going to be allowing for injury, especially if there is enough of it. It's also true that CTE has now been discovered in just about every contact collision sport that's out there. In our work, it's clearly related to the total amount of brain trauma that's been sustained, much more correlated with total number of hits to the head than number of hits to the head that cause concussion, although I suspect the concussive level of severity is much more injurious. This is a paper that was put out by the Mayo Clinic a few years ago, and I think the important thing here is that 21 of 66 athletes, 32%, that came from contact collision sports had CTE. None of the controls had CTE. So in this one particular publication, only the group of athletes that had head trauma had CTE. The controls did not. Other facts about CTE is it's under-recognized because it really can only, your brains are, in the past, have not been frequently studied with the very expensive, laborious, and time-consuming immunohistochemical stains that are needed to look for hyperphosphorylated tau. It's really important that all of us understand we don't know the incidence of CTE, we don't know the prevalence of it because it's not been longitudinally studied. We just know that we've seen so much of it that it's got to be out there in a greater percentage than what I believe is acceptable. The diagnostic criteria are confirmed and are agreed upon. The clinical syndrome is not yet defined adequately. There's too much overlap with other neurodegenerative diseases. Conclusions regarding CTE: a constant of all cases reported, with very few exceptions, is repetitive head trauma. It might point out that not all cases of smoking is there, in all cases of lung cancer is smoking necessarily present, but virtually every case of CTE documented, there's been a history of head trauma with very few exceptions. This is a...
Ira Casson leads a team of NFL doctors who did a study of several hundred active players and reported that the concern over head injuries is overblown.
Is there any evidence, as far as you're concerned, that links multiple head injuries among pro football players with depression?
No.
With dementia?
No.
I'm going to stop in the interest of time. I really love to play this clip, although it's not fair to poor Ira in a way, because we know him as Dr. No. He's listed a series of questions, and everyone is no, 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 no. And we now know it's yes, 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 yes. And even the Vice President for Health and Safety in the NFL, Jeff Miller, has acknowledged the link. As you know, the National Hockey League has sunk to a ridiculous new low, and I guess you heard about that yesterday, so I don't need to repeat that in terms of its stance. Not good. Led me to write a book in 2012 calling for the abolition of tackle football until high school. Not the abolition of football, just play flag, practice tackling, but not against each other. No heading in soccer, and no full body checking in ice hockey. Then it was 11, now it's up to 13 in ice hockey. In soccer, it's 10 below, there's no heading, 11 to 13 limited. Football is still a struggle. The reasons for that are that the brain in its especially between the ages of 9 and 12, are undergoing a tremendous number of changes at an accelerated rate that make it more vulnerable to injury. Not only is the connectivity that will give you your genetic endowed intelligence, your behavioral characteristics, your ability to handle frustrating circumstances or not, but your mood, whether you're going to be upbeat, et cetera, can be particularly injured during those ages. And we know a number of other things about the developing brain after brain injury that are not good, and I apologize for going through this so fast. So youngsters are particularly vulnerable, and we now have 4 studies from Boston University, our group, that all show the same thing. This was the first one in 2014, in which if you started playing tackle football under the age of 12, you had a greater chance for later life behavioral, mood, and cognitive issues. First study. Second study in neurology, 2015. Julie Stamm took the lead on this one. Different data set, but the same finding that individuals, greater cognitive, behavioral, mood issue if tackle football was started under the age of 12. Michael Osko is going to be the lead author on the next 2 studies. This one was 2017, last year, in translational psychiatry, looking at 214 football players, and the age of first exposure before 12 corresponded with a 2 times greater chance for impairment in behavioral regulation, depression, apathy, and executive function compared to a group that started later in life. Third paper basically showing the same thing, and then just last Monday, I guess that would be of this week, come to think of it, in the Annals of Neurology, our latest paper, this time in a group of people that died of CTE, and looking at whether they started football before 12 or after, and where their onset of symptoms were that were consistent with CTE. And then for every year before the age of 12, they started playing football, 2.4, roughly 2.5 years earlier onset of symptoms. And those as a group that started before 12 compared with after, had 13 years earlier onset of symptoms. So the fourth paper basically showing the same thing. Again, different data sets, same conclusion. And for those people that would argue that you need to start playing football before high school, or else when you do start to play it, there's going to be some greater risk for you playing, there's absolutely nothing in the world's literature that supports that. And this is a pretty good group of players: Walter Payton, Tom Brady, Curtis Martin, Jerry Rice, Kellen Winslow, so on, that played in the NFL, are all pro, Hall of Famers, and never played football before high school. So it's impossible to ignore, I think, the devastating effects of CTE. In our more recent published paper in JAMA of just football players, 2,000 were surveyed. If we look at the high school group of individuals, 14% had CTE, all of them stage 1 or 2, none of them in stage 3 or 4. Our college players, 91% had CTE, and our National Football League players, 110 of 111 studied, had CTE. Now, I need to caution that these are symptomatic people whose brains were donated because they were symptomatic when they died. So it's not representative of everybody that played the sport, thank goodness. But it's certainly scary. This is a paper by Philip Montenegro that dealt with showing that the greater number of impacts to the head somebody took, the greater the chance they would have for CTE. Again, pointing that it's not all about concussions. It's mostly about the number of impacts that you're taking and how many you take over a given period of time. This is a paper that substantiates, oh, I gotta run. This is a paper that substantiates that if you take a great deal more head trauma, that you'll also shrink parts of the brain that you'd like not to shrink, like your thalamus. And subconcussive changes have been shown to occur over a course of a season in junior football players. And now this is the work of Lee Goldstein and his group that was published this past December that looked at an injury model in animals, mice, and what it showed was that there was no correlation between concussion and CTE, but there was a direct correlation between repetitive brain trauma, the amount of it, and CTE. Best evidence to date that it's the hits, not the concussions, that are causing CTE. So with that, I am going to close, but I need to show you this one slide and take 5 seconds more. We thought forever that woodpeckers were wonderful and genetically endowed to take hits to the head. They struck straight forward with their beaks, purely linear acceleration, no rotational. They had a tongue that wrapped around the inside of their skull that gave them an extra buffer from brain trauma. And they had necks that were horrendously thickly developed. One problem, nobody ever examined the woodpecker. And recently somebody did, and when they did, guess what they found? Way more tau than was found in non-woodpecking birds. So with that, hope springs eternal. This is a group that we work with. This is a group at BU and our funding sources. And thank you very much.
Thank you very much, Bob. You didn't have to worry. We're just going to take the time off our next guest speaker. So I think next year we invite Chris and Ann and Bob back and give them an entire afternoon of talking about concussions. We not only appreciate your presentation, we also appreciate the work you're doing, not only for the USA, but for Canada and the world. So thank you very much, Bob, for all your hard work. Our next keynote speaker, you had a brief introduction yesterday from Dr. Hashizaki, is Scott Delaney. Dr. Delaney is an associate professor and research director at the Department of Emergency Medicine, McGill University Health Center, and McGill Sports Medicine Clinic. He practices emergency medicine and sports medicine at McGill University and the MUHC. Dr. Delaney had a fellowship in sports medicine and is a research director for the MUHC Adult Emergency Department. He is an associate professor at McGill University and is a team physician for the Montreal Alouettes in the Montreal Impact. Dr. Delaney is a member of the editorial board for the Clinical Journey of Sports Medicine, and his research interests include concussions and neck injuries in both athletic and emergency department population. Please join me in welcoming back once again this year, Dr. Scott Delaney.
Thank you, sir. So thank you very much for having me. Some of you know me as Scott, some of you as Dr. Delaney, some of you now know me as what? Stonehands. So thank you again for having me. I'm going to talk a bit about the school-age child. And in the background, a question that I get asked quite a bit is, should my child play contact sports? So I have no conflicts of interest at all that would affect this talk. So what we're going to do today is we're going to go through looking first at what sports our kids play. And again, I've been browbeaten in the past that we always jump to NFL players and what have you. And educators have often told me, I look after 7- and 8-year-olds. I don't look after professional football players. What happens to them? So we'll look a little bit at the young child and what sports they're doing and how they get injured. We'll look at risk factors for concussion. And again, always keeping in mind that parent who's asking you, should my child be playing this sport? We'll look at some of the long-term effects. And again, I don't want to get into CTE. I told Bob, I knew I wasn't going to touch it. I said, it's like getting up after Jesus Christ has spoken and sort of preaching the gospel. I said it wouldn't be well appreciated. We'll look at education, which is obviously a big thing, and with Rowan's Law, it's going to be very important. But there's a caveat that comes with education in terms of the effectiveness of it. I'll tell you what we've done with our concussion contracts, and we'll look at return to learn, which you guys obviously, as I'm learning, probably know much better than I do. So, again, I get asked a lot, should my child play contact sports? And obviously, every parent wants what's best for their child. And really, what I think I hear in Montreal is when somebody says, should my child play contact sports, is I really want my child to go to McGill eventually. So everybody wants what's best for their child. Nobody wants a second-rate education. Nobody wants to send their child where they may not be looked after, as they often should be. So that's what I hear in my head. And I will just say that Blaine has a son and a daughter, and his daughter is going off to do a PhD in Cambridge, and she just graduated from a certain university. Which one was that, Blaine? It was in Ottawa, okay? So anyways, enough of that. So, although there will be a couple more digs as we go along, unless I run out of time. So listen, let's look at the young child, because we oftentimes focus on the professional players and what have you. What sports are the young children playing? So not the teenagers, the late teenagers, but most of the time you look at those are the five top sports that kids are playing. So the young kids are not playing football, they're not playing rugby, they're swimming, playing soccer, playing ice hockey, basketball, and what have you. So that's what they're doing. And why do kids do that? Why do they get involved in sports? They don't want to go on to be a professional player. They do it for other reasons. If we look at what sports they're playing, you can divide them into the contact or collision sports. And this is the American Academy of Pediatrics who's done this. And they look at contact sports and divide it into collision sports, which are sports where you intentionally hit somebody. So those are the football, ice hockey, rugby, and even rodeo. And then the collision sports where you're going to bump into people, but perhaps not intentionally. And those are the soccer and basketball sports. So if you look at the top three that are there, those are some of the top 5. And then limited contact sports, again, baseball, which is in the top 5 of the sports. Swimming is the one that's not listed there, and that's the non-contact at all, obviously. So, I could cut this short and just say, put your kids in swimming, goodbye. But I won't, I'll move forward. So why do people get involved in sports, and why do kids get involved in sports? And this is, when you ask, should my kid be playing contact sports? You're getting them into sports for certain reasons, and that's why the kids do it. They do it for fun and relaxation. They do it for health and fitness. They do it for feedback, positive feedback. And if you look at the psychology of it, the psychologists will tell you team sports are probably better than individual sports in terms of building social awareness and social interaction. And if you fast forward, if you meet people like tennis players who are #1 in their field and what have you, it takes a very certain sort of individual who's very headstrong and doesn't mind spending a lot of time being together. So if you're looking for your child in terms of I want to do what's best for them and exercise and I want them to get along, team sports are probably the way to go. That's not to take anything away from tennis or what have you. So Bob has sort of obviously mentioned this. In the past 10 years, the number of kids being diagnosed with concussions, and I come from a bit of an emergency department background, and the number of kids who are presenting to the emergency department has increased vastly. And as Bob said, they're getting bigger and stronger. I don't know that 5- and 6-year-olds are getting bigger and stronger, but I think that we're more aware of it, and parents are more aware of it. And again, they want what's best for their kids, so they're more in tune with it, and we'll bring the child in to be checked out. But in that young child, okay, so how are they getting injured? We run to football, ice hockey, because that's where we do the studies, and that's where it's easier to follow. But if you look at the age groups in terms of males and females, you'll see just in terms of playground injuries, how common that is to be involved in an injury. And you probably know that better than I do, looking after kids and coming back from recess and coming back from lunch and there's an injury. You add in bicycling to that, and you look at how often that's responsible for concussions in the young age group. And certainly to give credit where credit is due, Blaine has done a lot of work on helmets and what have you, looking at helmets that have prevented catastrophic injuries. It'd be hard-pressed to find a better helmet than a bicycle helmet in terms of the numbers and what they've done to protect. And again, in terms of wanting to do its best, but not understanding perhaps the consequences, for a while there was a push to have children wearing bicycle helmets on the playground. And kids started wearing bicycle helmets because they were banging their heads and what have you. But again, for every action, there's something you don't expect. And what happened was kids were dying on the playground with bicycle helmets because they were getting the strap caught on certain parts. So they were basically being hung, asphyxiated. And other kids, kids have an enormous head, as we'll talk about proportionally, bigger than Blaine's, but almost. But they can get their body through certain things, and then the head with the helmet would get stuck. And they would sort of be asphyxiated because all their weight would be on their chest as they struggled to sort of get off. So, what was thought to be perhaps be a good thing ended up being a bad thing. And they looked at, what can you do? And Blaine was probably more involved in this than anybody here. They looked at, okay, well, maybe we need the straps to come off after a certain amount of pressure or time because you don't need that in a bicycle crash. Or maybe, we need to change all the openings on the playgrounds to making it really small. But probably the best thing to do is to ensure your kids don't have a helmet on there and, that they don't have hoodies, neck strings, anything that can be caught when they're out playing. And that's, again, for the younger age group, if you step back and look at what's best for them. So again, these next slides, you can pick a million studies that are done and look at, as you get into the high school age, what sports are most common in terms of concussions. And the big ones are always there: football, hockey, which is not included in this study, soccer, wrestling, other things. If they have rugby, that's often involved. Again, if you look when hockey is involved, it's often near the top. This study didn't look at female hockey players, but I can tell you that we've looked at McGill, and theoretically female hockey is a non-contact sport, and we have just as many concussions in our female hockey players as our male hockey players, and they end up being out longer. And that may be due to the mechanisms, because the males take more concussions from the shoulders and elbows, and the females hit their heads on the ice and the boards, which is much less forgiving than somebody else's shoulder and elbow. So as you get into high school, these, and as I said, you can look at a million different studies, but those are the big ones. When you look at, again, should my child play contact sports, you look at, well, let's see, when should I get them involved? And we think, and Bob had mentioned this a bit, that we think kids are probably more at risk for a number of biomechanical reasons, but also, again, it's hard to believe, but a child's head is 50% of the size of an adult's when it's born. There's no other part of the body that's like that. That's an enormous target out there. And this giant bobblehead sits on top of this little neck, just sort of sliding back and forth. And as Bob had mentioned, we know the neck is very important. And we think the stronger your neck is, and I believe this, and I think Bob does, the more you can absorb the force. So you have this giant target out there that has a thin skull sitting atop a bobblehead getting hit, and we think that that's probably one of the reasons they're more at risk. They have these weak neck muscles that really aren't developed until they get into their teens and beyond. And anybody ever watch kids sort of head a soccer ball? Anybody ever coach soccer? It's not a human thing to want to put your head into the space of a soccer ball. This is what it looks like. There's a sweet spot right along the hairline that if you don't catch it, it hurts, right? So you get it in the face, you get it on the top. Kids aren't good at doing that. And as Bob had mentioned, USA Soccer is outlawed heading for kids 10 and under, and Quebec Soccer is looking at doing it for 12 and under. And Bob, they're longer to recover. So kids in general are more at risk. You look at what sports you're playing, right? So obviously you don't want to put your kid in the octagon, right? At 7 years old for ultimate fighting. But you have, the big sports that are there. And I'll be honest with you, the reason I got involved in concussion research was two. One was I started looking after football and soccer at McGill, and I came from more of a football, ice hockey background, despite what Blaine says. And I couldn't believe the amount of kids who were getting injured with soccer. We were losing more kids to soccer than we were with football. And I thought, this is news to me. The other reason I got involved was because of the CFL players, that when I would go to ask them questions, you were dealing with guys who were lawyers, and let's just say other guys who were not lawyers. So I'd be asking him the questions, and I thought, he'll never know the answer to this question. You know, we had one poor guy who didn't get mail for a year because he told everybody in the US his address was Montreal, Ontario. I'm not getting any mail. Well, you're having it sent to Ontario. Montreal's in Quebec. So there are other things. You know, you look at gymnastics, cheerleading, all those. Cheerleading is basically gymnastics over a hardwood floor, isn't it? So a lot of the things which don't get the attention are actually at high risk for concussion. You look at past brain injuries. So we know that people who've had a past brain injury are more likely to have another one in the future playing the same sport. And you ask yourself, why is that the case? And Bob and I were discussing this a little bit last night. I think there are people that are anatomically predisposed, and we've seen that in boxers. And again, Bob makes a point that, you know, you don't have to have a loss of consciousness to have a concussion, but there are boxers who have a glass chin where you hit them, they're out. And they get knocked out. And other guys you can hit, they never go down. So people have a different response to the same amount of force. And just as we think some people might be more susceptible, I think there are people who are actually protected from that they can take blow after blow after blow and not perhaps reveal as obvious clinical signs. It doesn't mean they're getting concussions. It's a bit, are there any Simpson fans out here? The show? There's a great episode where Homer has a layer of fat around his brain, so he takes up boxing because he can just get in there and get hit and can never get knocked out. That's a bit of a stretch, but I think that that's probably the case to a certain extent. There probably is some sort of scarring that goes on in the brain, and for years we couldn't see it. Now, as Bob mentioned some of the things that we're looking at, we can see some of the scarring that has happened, certainly in the past and perhaps acutely. That was a problem because you'd see athletes and you'd tell them, you know, oh, you're not good. Yeah, the CT scan was normal, but, you know, you're not behaving, da-da-da. And it was a bit like, you remember Charlie Brown where you hear wah, 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 wah. That's what they would hear. They'd hear wah, 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 wah. Your CT scan is normal. Beautiful. I'm good to go. And it wasn't. Now we can look at that and actually document sort of changes that are there. You look at a child's style of play. Are they an aggressive player? You know, yeah. I could tell you that Blaine Hoshizaki, well, if he ever got on the ice, would be more at risk for a concussion. Thankfully, we kept him on the bench. But he's obviously going to be more at risk for concussion because he likes the contact and likes to be hit versus somebody else who's very good at dodging contact. And then there's also we're going to diagnose more concussions in the squeaky wheel. The athletes who are more honest with their symptoms. Obviously, we're find more because they're going to be more forthcoming with their symptoms. And again, we come back to that you need the athlete to come forward and volunteer his or her symptoms. I can have a team of neuropathologists, MRIs, what have you. You're still so dependent on that very basic mechanism of an athlete volunteering his or her symptoms to you. And again, we'll get a bit more into that when we talk about the education. People who don't sleep well have a lot of changes that are very similar to a concussion. And I believe people who don't sleep well, meaning they have trouble falling asleep or sleeping less than usual, take longer to recover from a concussion. You, as educators, may see this in the kids who aren't able to focus or what have you. We know from a concussion point of view, they have more abnormalities at baseline, and they have more abnormalities when they do get concussed. And we think it may take them longer to recover, whether that is actually just that it's a pure concussion that's not recovering, because I think sleep is really important in the recovery process, or whether the symptoms are just overlapping. It seems like it may take them longer to recover. And even if you don't sleep well for a few days and you get into a functional MRI, you have changes that are similar to a concussion. So you're not as focused or what have you. It's when you do neuropsychological testing, and we do it, but you have to understand it's neuropsychological testing. It's not just concussion testing. So in the absence of learning disabilities or what have you, and everything was great, and I hit my head yesterday playing football, well then these abnormalities are probably related to your concussion. But you don't sleep well, you're not going to do well on that neuropsych test. It's very similar. If you have pain, you have anxiety, you're distracted, you won't do well on those things. And sleep can affect that. And I think it takes people longer to recover if they're not good sleepers. And it's a hard thing to change with that. You're either a good sleeper or you're not a good sleeper. You can make some changes, but not a lot. Females, I personally think females are more at risk for concussion, and I think it has to do with the anatomy, and I think it has to do with the fact that their necks are not as strong as males. You know, if you look at, let's say, university soccer, there's a little bit of a difference in terms of the speed, but not a huge difference, and yet the numbers are significantly higher. And if you look at just soccer, for example, females, the ball being involved in soccer-related concussions is much higher than males because I don't think they have the neck strength to absorb the force there as compared to a male. And even in our male soccer players, we have a study that's sort of ongoing. We're measuring their head and neck circumference. The guys who have big necks seem to be better prepared and less likely to be concussed, but that's an ongoing study we have. But the experts are not sure because there are differences in the games. Like I said, if you look at female hockey, which is a non-contact sport, yeah, the concussion rates are similar and they tend to be out longer, but the mechanisms are different. The guys are getting hit with elbows and shoulders. The females are hitting their heads against the ice and hitting them against the board. So different sports, different mechanisms of injury. As educators and as parents, you have to be aware that, you know, obviously not all kids are created equal, but when you have a child who has a learning disability or attention disorder specifically, first of all, when they do tests like neuropsychological testing, it always looks like they have a concussion. They don't do well on those tests. They have a hard time concentrating to the point that when we do research, we'll oftentimes take them out of the research project because it's so difficult to know when they're back to baseline. When you have a child who has those learning disabilities or attention disorders, they're already a little bit behind the 8 ball, and if you add in a concussion, it makes it so much more difficult to figure out whether they've actually recovered. There's conflicting research on whether they may actually be more predisposed to concussions, but we know that if they do get concussed, it's so hard because they always have a low level of symptoms, and it's hard to know when they're back to baseline. So when you're trying to decide should that child play contact sports, that's something you have to remember. If they already have learning disabilities or attention disorders, contact sports may really complicate matters if they get a concussion. Migraine headaches, we know that obviously you don't want any child with any headaches to be playing contact sports because it confuses the issue. You don't want somebody out there with a headache already and then they get hit and you don't know whether they have a headache. But if you look at the recovery, it's prolonged with migraine headaches. So you're already dealing with that. So these are things when you're making that decision, should a child play contact sports, you may want to look at. Let me just ask you as educators, do parents ever ask you, should my child be playing contact sports? Do you ever get that? Now, you do? Yeah. And what do you say? For everybody? Well, it's consistent. Yeah. Good. No, listen, it's not an unsafe thing to say, right? Like, so, and we'll get to it later, but they look to you guys for guidance. And it's one of the things I wonder about when you know, with the laws and stuff, do you just feel like you're being overwhelmed now as an educator? Like, because as I put myself in your shoes, I feel like that I got enough on my plate to begin with. Like, do I need this? So hopefully with the training that you get, but let me just see, Warren, close your eyes. Quick show of hands. How many people feel like they're a bit nervous about this because this whole education you're responsible is going to be just a bit overwhelming? Okay. Again, putting myself in your shoes, that's what I think as well, but hopefully we can all do this well together. So then you look at, okay, my child, what happens if they get a concussion? What's going to happen weeks to months later? And again, after, you know, metaphorically, Jesus Christ has spoken. I'm not going to speak about CTE, but, you know, some of the things that I know from my research is the more concussions you have, the longer it takes to recover on average. Every concussion is different, so you can fall and hit your head and be out 2 weeks, and you can fall and hit your head and be out 5 weeks. But on average, if you take 1,000 concussions, on average, the third one is probably going to take longer than the second one. And the second one is going to take longer than the first one. So we've seen this in our studies, and others have done it as well, but just because I know my own studies quite well, you can see there with subsequent concussions, it takes longer and longer to recover. And I'll just say that that's clinical recovery. Bob I'm an emergency sports physician, so, I have the attention span of a gnat. So I'm like, let's go. Let's move on to something else. Bob deals with the brain, and, they'll tell you that even when clinically you're good, the brain is still healing. And we were discussing last night about that. I think we'll look back and say, you went back after 7 days? Are you crazy? And, again, I wasn't there when this all started, but my feeling is why there's nothing medical or physiological about 7-day return to play steps, right? You know why I think there are 6 or 7 return to play steps? It's nothing because that's how long the body takes or what have you. It's because there's 6 or 7 days between a football game. So you get hurt on Saturday, things are going well. I want you to play on next Saturday. I don't want 8 steps. I don't want 9 steps. I want 7 steps. I want you to get back. And I think as we learn more, that sort of 7 steps keeps getting pushed out longer and longer and longer, because even when you're good, I know 2 + 2 is 4, good for you, and you have no symptoms, inside the brain is still sort of healing. So we've almost got to build in a buffer area for that. You guys see this maybe more than I even do. Most concussions, as Bob said, get better quite quickly, clinically anyways, clinically. So most of them get better within a few weeks, but if you look at that slide, this is what I see. You see a kid who's had a concussion at 5 months, still symptomatic, you're not going to hit a home run with that kid in a week. He's on the flat part of the curve in terms of the healing process. So as educators, you need to know that. Sally's coming back. She's had concussions for concussions. She's bad for 4 months. Sally won't be better in another week. Little Billy had a concussion last week. He might be better in a couple weeks. Sally is symptomatic after 4 months. She probably is not going to be better within a few weeks. So you get out on that flat part of the curve, and you guys need to know that, just that, the longer it goes, the slower the recovery is. There's good days and bad days, but overall there's a recovery, but it's slower the farther out you get from that concussion. So just be aware of that in the classroom with those kids that are going weeks and months. It's a slow process versus the other kid who just got concussed and might be better in a few weeks. So I'm not going to touch on this. I put a picture of myself in there because I used to speak to the military before they went off to Afghanistan, trying to get some street cred. When I was in the Army, they weren't buying it. They're like, hey, you were just driving around like the city. We're going to Afghanistan. So Bob has obviously mentioned this. Some of the other things, the depression, Dr. No, I hadn't heard that. That was pretty funny. And again, there's a lot of sort of smoke around that. You have to convince yourself whether there's fire, but this is stuff that gets a lot of media attention for parents. And these are the type of questions you're asked. Is there more depression? Is he going to get CT? Is she going to have, Alzheimer's disease? And you have to be aware of that. And again, the science, I agree absolutely with what Bob said. The media is doing this, and we're sort of catching up. And when the world experts get together and they can't come to a consensus and they read everything, you have to take stock in that, because it's hard to keep up with everything. And when you do it and they're like, seems like there's smoke there, but we're not sure about the direct relationship. That's the best that we know right now. So Bob had mentioned this as well, in terms of some of the things you can do to make contact sports safer. You look at no contact sports before 14. I think the best research that's been done is looked at ice hockey in terms of eliminating contact in Pee Wee hockey, so 12 and 13-year-olds. When you compare Alberta, which allowed contact hockey, to Quebec, which didn't, you had 3 times as great an injury, a risk of having a major concussion or just any other major injury when you had contact hockey in that. And that's probably the best evidence, looking at age groups in terms of contact. Can we hit safer? You know what? Just take it out of the game. My son now, is 13, he probably will never play contact hockey his whole life. And I played it my entire life, and I was a really good hockey player. But I just played it my whole life, so he'll never play contact hockey, and he's a decent player. He's not. Unfortunately, he inherited these a bit from his old man, so but he'll probably never play. You look at, pitch counts are quite big in baseball in terms of how many pitches is a child thrown. And those of you who look after baseball, you pull kids, right, at certain age groups. You've pitched 40, you're out. 50, you're out. 60, you're out, different age group. Thought, can you do that in football? You know, should you only be allowed a certain number of hits? It's obviously a more difficult thing to keep track of than how many pitches have you thrown, but that's what we look at. Decreasing contact in practices, we'll look a bit about that. The CFL has now just said there'll be no really contact practices once training camp is finished. The only type of practice you'll be allowed to have is where you're just wearing a helmet and a jersey. So no, you're not going to be hitting with that. And before they'd only allowed a certain number, but now they said we're done. No more contact after training camp. Now, granted, training camp is 2 weeks of Lord of the Flies, of like people killing each other, you know, fighting for survival. But after that, you're good. You make it out the other side. You look at soft headgear for soccer. I had done a study looking at it in Oakville, and it's really a hard thing to study because not a lot of kids wear it. And we found, again, this was athletes sort of answering it, that the athletes who wore it seemed to be less prone to concussions. Look at neck strengthening, and again, I believe it makes a difference, but the studies that have looked at neck strengthening haven't really shown it. But yeah, again, to go back to that old adage, the absence of proof is not the proof of absence. You know, just because something, like I always tell people, I've never studied that driving down the road in a red convertible doing a handstand, steering with my feet is dangerous, but I'm pretty sure it is. You know, but there's no proof that it is, but I'm pretty sure it is. So sometimes you have an idea, and even though you haven't been able to prove it, you have to look at it from another way. And I think that's what it's going to be like in neck strengthening. When they've had different exercises, it hasn't been shown to make a difference. I just think we haven't done the studies yet. So there's a big push now for football, you know, no hitting forward with the head or what have you. And just one of the doctors who trained me was a guy named Ray Brown. Ray is a house. He was like 6'4", 260 pounds. And just to show you, like Ken Dryden would say, those "what are you thinking" moments. Ray said he remembered he played football at McGill, so he was a smart guy. And they got to suspension helmets. So suspension helmets, for those of you, it's a hard plastic shell with, it had a canvas strap and a piece of foam here and a piece of foam there. That's sort of basically what it is, eh, Blaine? And they had nothing before that. So back in the day, the one injury that really you had no operation, if you dislocated your shoulder, you were out because there was no operation for that. So it was like, oh, you know, we don't have an operation, you got to stop playing football. So they got these new helmets, and the coach was like, boys, we're good. Nobody tackle with your arms, everybody start hitting with your heads. And this, honest to God, he said for 2 weeks, all they did was hit each other with their heads. And he's a house. I can only imagine what the other guys were like. He said he remembered going home with headaches and feeling nauseous after practice to the point they had to go back to the coach and say, this is not working out very well. But it's just funny, you know, like, what were you thinking? Well, now we know. But back in the day, it was like, oh, thank gosh, we're going to prevent those shoulder dislocations. Everybody start hitting with your heads. Helmetless tackling, again, that's sort of what the CFL is doing. And some of I think this is University of New Hampshire, they sort of looked at it where, you know, obviously you're not wearing a helmet, you're not going to want to put your head in there and crank somebody. So they learn how to do it without their helmet just because your tendency is not to want to hit with your head, and you end up hitting more with your shoulder. So that's something we're looking at. And again, the CFL, as I said, is outlawing any contact practices. Proper technique. So again, you're looking at when you do start heading, you've got to do it. And a lot of times they'll use a bit of a piñata model where you can sort of learn where the soft spot is on your head or the best spot to hit. But perhaps it's best just to eliminate it in certain age groups until their musculature and anatomy is better, and they're probably more skilled to be able to do it. So proper body checking in hockey, you know, again, I don't want to get into a whole debate. The goal of body checking in hockey is not to send somebody into the third row, right? It's just not the goal. The goal is to knock him or her off the puck and take it. So we're looking at, you know, Hockey Canada has different instructional videos, but it hasn't been shown, not that it's been the best studied, and I think the best thing to do is, unless you're really good, and you might be going to play college hockey, or you got, at let's say, a AAA level, I don't think you need contact in hockey, to be honest with you. I don't think you need it, because my son is not going to the NHL. He's got these, so why does he need it? He still gets the fun in the exercise that's there, so maybe we forget about, you know, proper techniques. For most kids, just take it out. The other thing when you're diagnosing concussions is assume that the athlete has no idea, and I think we're getting better, with that or assume that they're lying to you, okay? And I tell you this because, and I don't know if I told you guys this story, when I was here last time, when I did my first study with the CFL, I was stupid enough to send it out and have them put their names on their papers. So I said, last year after being hit in the head, were you knocked out? Nope. Last year after being hit in the head, did you have headaches? Nope. Nope. No, I got all these things back, and it made no sense because I asked them about high school and college, and it was like, well, the guys at McGill have way more concussions than these professional players have had, even at the same level. What's going on? And we had done it with the union, and they said, listen, Doc, you're a good guy. But they think you're going to let the information out to the teams. They're nervous. The only guys who answered that they had concussions were the superstars on the team. So although he didn't take part in the study, let's say like an Anthony Calvillo, who's like, what are you going to do, cut me? You're not cutting me. I had 4 concussions, you know, I'm good. Anybody else is like, no, I'm good. So I wasted, you know, several months with that, and I sent it back out anonymously, and we found that probably 45% of all the athletes had had a concussion in the previous season. We went from nothing to 45% when we asked them not to put their names on the paper. So they oftentimes know, and they're just afraid to tell you that that's it. And that's what athletes do. Athletes filter, right? So you go into a football locker room, ask them, do you have a headache? They'll say, no, I don't have a headache. Really, you have no headache? And you push them, they'll say, oh, my usual headache, but it's not abnormal. You have any neck pain after football? Yeah, ask a linebacker at university, you have any neck pain after football? No. Really, none? My usual neck, as they're sitting with a bag of ice on their neck, my usual neck pain, nothing bad. So they're not, you know, computers that are binary of yes, no, I have a headache. They filter like, nah, I think this one's not normal. And you'll see that that's what they do. So they lie, first of all, and then they filter like, nah, it's just a normal headache. So what we discovered in the emergency room, a bit like what I was talking about, is that it's not that you had a headache, it's that you had a bad headache that you came to see me. So it tended to be the severity of the symptom. Now again, you know, the state of the emergency rooms across Canada and in Quebec, where you're like, that's going to be an 8-hour wait. You know, am I really going for this headache? So let's take that into consideration. But it wasn't that they had symptoms that brought them in to be seen for head injuries. If it was very severe, they would come in. So it's when they were scared. The number one symptom that brought people that makes people go after being hit in the head, this is not athletes, these are the sort of emergency department population, in terms of any clinic, anybody take a guess? It's something we poo-poo. It's not really fun to have. Nausea, okay? So people don't like to be nauseous. And the number one reason that you'd actually sit for an 8-hour wait in the emergency department was loss of consciousness. And look at it, that's a third. So 2/3 of the people who were being hit and knocked out were like, I don't need to go in to be seen. So you got to remember that when you do the education for athletes. It's not just if you have a headache, they'll filter what they're thinking about. They'll do the math in their own head and decide if it's serious enough to come and see you. So, but we have to educate, right? So, and it's funny because when I was one of the questions yesterday was something about it takes a village to raise a child. And sometimes it takes a village to make a diagnosis of a concussion. I don't know how that kid is going to be as he sits and looks at 6 hours of PowerPoint presentations or smartboards during the day, or does math, or what have you, but you do. You know what they're normally like. Again, it's like me sitting in a dark, quiet room saying, do lights bother you? No, because does noise bother you? Doesn't seem to. Yeah, because I'm in a dark room that's not noisy. I don't know till they're exposed. And some symptoms are delayed, but others are just the fact they haven't had the test yet. You guys are there when they have that test. So that's why it's so good that you're being educated in that, because you can pick up on stuff that I wouldn't do. I mean, listen, sitting in school is a 6-hour neuropsych test every day. Okay? It's, unless you're going to certain universities where they're just mailing it in. But that's why it's honestly easier, from my point of view, to deal with students in terms of diagnosis, because they'll come in and say, I can't do calculus, I can't do math. The pro guys are hard to deal with because they do the same thing over and over and over, you know. So this is a true story. This is one of the CFL players who had a headache on Saturday, but his normal headache, didn't come to see me till Thursday, and he said, I didn't really, I had the headache, but I often have a headache. It wasn't until I was in the bank and I was trying to add my bank statement together that I realized I couldn't do it. Because they do repetitive plays, they don't hit each other too much. I mean, yeah, they play Nintendo or whatever it is, or Fortnite now, I guess, all the guys. But there's not a lot of new information there. This guy was adding 2 bank statements together, and he had stepped out of his comfort zone. And again, this is CFL players, so this is not 31,317. This is like paychecks of 250 plus 250. These are not big numbers, okay? He was just, that's an honest to God true story, and he didn't know. You guys are there when it happens. So I always tell medical personnel, don't be embarrassed to make a concussion later, because it may be in delayed onset and symptoms, and it may be that they've not had the exposure. But you'll see that sometimes where so-and-so went back into a game, and then they don't come out for another period. And it can be an intimidating thing to make a diagnosis of a concussion, first of all, but even more intimidating to almost come to the realization that, you know what, we thought she was good and she's not good. Let's pull her out a bit. And that's not wrong. It may not have been evident, or they just may not have been exposed to it, but don't be intimidated. And that goes for you guys as well. On Tuesday, listen, Sally's not right. I don't care what they're saying. She's just not focused or right. Bring it to our attention, because we're not there. You guys know them better. Again, there's a lot of good resources, and I saw you guys had those. There's handouts out front. But you want to make a good diagnosis, because perhaps the most important thing in preventing another concussion is making sure we caught that first one and really allowed it to heal well. Because again, the school of thought is, if you're still having symptoms from a first concussion, your threshold for another concussion is lower. So if you need to be hit like this to have your first concussion, theoretically, if you're not fully recovered, that may bother you. And I've seen that. And Bob has probably seen it much more than I have, where guys will come in and say, you know what, I got hit on Saturday, it was bad, and I just was blocking on Wednesday, which we always do, and I feel like I just got hit again. So, and again, remember, the second one is going to take longer than the first one, and the third one is going to, and that's how you get buy-in with students and athletes. You say, listen, I'm not happy you have a concussion, but we treat this well. Hopefully you'll be back sooner, back to 100%. If you push it and you get another one, you're going to be out even longer. And for athletes, you dangle that carrot in terms of, well, I want to play the most possible, so I need to let this heal so that I'm 100% good and can go back. Even in hamstring injuries, you do that. You pulled a little bit of your hamstring, it's not bad now. You pull it again, it's going to be a worse injury. So you got to make the diagnosis as much as you can. And if it's delayed, don't be nervous about it. It's very helpful to us, because you know better. In all honesty, I'll see kids, and Bob will tell you, I'll see them on the third visit and realize how different they were on the first visit, just in terms of, their flat affect and flat energy. It's not a thing we can test for. There are, I can't tell them a joke and tell them how hard is he laughing. He should be laughing harder. Later on, I'll realize, like, hey, doc, how are you? Like, oh, this is a different child. Educators and parents know that, and it's hard for us to judge that. I'll see it in retrospect, but hopefully I haven't screwed up and allowed them to go back, and I realize, whoa, that wasn't Sally. She's not, a quiet girl. She's very bouncy and energetic. So, again, you educate the athlete, and here's the caveat. As I told you, they filter their symptoms. We looked at university athletes, and again, it's university and professional, but I think you'll get the point. We looked at university at males and females playing football, hockey, rugby, basketball. I think that was it. And we looked at our professional football players. And I asked them, because, if you don't know what a concussion is, you're not sure, I don't know. But I said, listen, forget about I don't know. Last season, when you knew you had a concussion during practice or during a game, how often do you think that happened? And then when it did happen, how often did you come to see us, and how often did you not come to see us? And first of all, what was amazing is that the answers and the percentages between this male and female university and the professional football players were almost identical in terms of the numbers. Almost 20% of the athletes said, yeah, last season I probably had a concussion. I shouldn't say I had a concussion. I was sure I had a concussion. And about 80% of those athletes at some time didn't come to see us. Because you had three groups. You had let's say the squeaky wheel who always told us, and that was about 15%. And then you had some athletes that, yeah, I did once, and then I didn't for the other because it was an important time. That was about 20-25%, but the vast majority never told us. So, but about 80% of the athletes at some point admitted, I knew I had a concussion. I didn't come to see you. And it's crazy, right? And because what I learned, we studied these athletes before, and what I found was they were so much more educated than when we studied them back in the late 90s. They knew, like, no, I get it. I knew I had a concussion. Like, I knew I had a headache and da-da-da. They know it, but they still didn't come forward to see us. And you look at the reasons there, the number one reason was they didn't feel that it was dangerous. One of the other big reasons was I had done it before and nothing bad happened. And then you get into I didn't want to let my team down. I didn't want to let the coach down. And for the professional players, money and contract status was way down on the list. So this is not a professional football issue. This is an athletics issue. And again, it's at university and professional, but the university athletes, these are not kids who are going to make money playing sport. And they still do it. It's an athlete thing in terms of not wanting to let things get away from them and not let anybody down. And listen, telling you professional football players hide symptoms, you're probably not falling off your chair, right? Oh, there's a shocker, Delaney. But yeah, we know it, but now I have a better idea why they're doing it and what can I do to change it. Because I'll tell you what, and this is where I'm looking, my research is going now, is changing human behavior is really difficult. The obvious approach of saying, hey, look at this. This is so bad, you're going to stop, aren't you? So you look at smoking, right? So again, this oftentimes comes up, but there are people out there who still smoke cigarettes, and some of them can't afford it. There have been studies on welfare recipients who still smoke, who will go without electricity to smoke. And you think, that's crazy. It causes cancer, it's expensive, cardiovascular disease. And when you ask them, why do they do that? One of the answers was, you know what? It's one of the few 5 minutes of every day that I get for myself. My life is so hard, but for 5 minutes a day, I get some indulgence, and oftentimes they get together to smoke, and it's their social circle. And once I'm not saying I agree with it, but I get it. I get it, Same thing with overeating. Hey, the Happy Meals, the 6 Happy Meals for lunch, they got to stop because you're diabetic now. They know, no, I understand, but that's the only thing that gives me happiness, or I do it for other reasons to go. We know they do it. To change it, you've got to understand why they're doing it. And that's where we need to go with concussions, because, yeah, there's some kids and athletes who, when you tell them it's this, they'll do it. Like I said, in the CFL, you always had the squeaky wheels who always did it, but other ones who will not do it. So you have to do it, but sometimes education is not going to be enough in terms of providing them with that, because we've seen that with other behavior. Some people aren't going to change. You have to figure out why they do it and try to address those issues. So one of the things we did, and again, we're certainly not the first to do this. We have concussion contracts at McGill and in and around Montreal, where we have parents, coaches, and players sign contracts. There's no legal binding agreement, where they read the information package on what is a concussion, and they agree to a sort of code of conduct of what will happen. So this actually, one of the impetuses was I was the assistant coach once, and I pulled a kid out who had headaches and hit his head on the boards, and the dad went ballistic. Has anybody ever pulled a kid out of sport, like for that? Anybody ever have a parent just go ape on you? And I said to him, it was a scene. Honest to God, it was a scene. Like, he was up in my face, and like, so God forbid this happened in Dryden. They'd be digging him up now. And I thought, I said, another one goes missing in Dryden. There's a shocker. I said, but listen, and this guy was the calmest guy ever, but I wasn't the head coach. And I said, you know what I do for a living, right? He's like, yeah, I know, but you're not the head coach. And da-da-da-da-da. It was crazy. I couldn't believe it. And I felt bad for a recreational coach who works as an accountant or a mechanic, and he's trying to deal with kids on the ice, and he's not medically inclined, and people are going berserk. So Coaches sign it, parents sign it, players sign it. They sign what they're looking for. They sign that they're going to look out for other athletes because, again, it takes a village to make a diagnosis of a concussion sometimes, and what has to happen. And part of it is I just want everybody to know that coach who's an accountant, when a kid complains of a headache, and you'll get asked, there was asked that question, somebody said they had a headache for a couple minutes and da-da-da. If they have decided to tell you that, they've already self-selected that that's abnormal. If they've actually said, I've got a headache, and that to me is you're good, you're out. Because I know they'll sit there with a lot of symptoms and won't tell you. But as a coach who doesn't have a medical background, I want the cities and the municipalities and whatever, the recreation leagues, to have that in there, that if a kid is complaining of a headache, I'm not a doctor, I am actually, I just play one on TV. I was putting myself in the shoes of the accountant. I just gave Blaine fodder there, that's good. But you don't know, it's not your job to know that. So listen, we'd rather catch, pull 10 kids out and maybe 3 or 4 of them didn't need to than to miss it. And everybody agrees. So don't start going ape if I pulled them out because Sally said she had a headache. You agreed to that at the beginning of the season, and this is what has to happen. We all bought into that. So anyways, we'll see if it makes a difference. You guys know the return to classroom, right? So in terms of that, one of the points that, again, you probably know this better than I do. When the kids first go back to the classroom, it's a very hard thing when you're learning to listen to somebody, to read off a board and take notes, right? So one of the things is, as much as possible, you want to provide them with the notes so they can just sit and listen and sort of get the concepts. If they're worried, they're trying to write and listen and copy off the PowerPoint, it's very difficult to do that. So usually, if you have the notes, or usually you'll get them from somebody who's a good note taker, which is usually another female, because males have writing like me, they'll be able to read. That can be very helpful as they get back in, because it's not an easy thing to sit and look at PowerPoint for hours a day and to divide your attention up 3 different ways when, as a concussion, you almost behave like you have attention deficit disorder until you've improved. So, so that's the concussion contracts, and to get them back in. So again, let's go back to that parent who asked me, should my child play contact sports? Well, like Bob said, I don't think anybody, listen, you don't play football till you're in high school. What did you miss? Running and throwing? It's not like, let's say, ice hockey, where you're like, well, you haven't started till you're 17. You're probably not going to, there's no specific skill to football that you need that you're going to miss out on. You could pick it up later on. If you're a good athlete, you're going to do very well. So I don't think you need to be playing contact sports before 14. Are you an aggressive kid? Are you a little Hoshizaki? Are you going to go berserko out there? Luckily, you probably won't see the ice, so that won't be much of an issue as you get in there. You have to, maybe this is not the best sport. Obviously, you're looking at, but there's boxing versus soccer. I'm being a bit of a silly in terms of using boxing as an extreme example, but these are things. And past injuries, sometimes one concussion is enough, in the sense that Sally had one concussion and it took 12 months to get better. And you want to put her into, I don't know, some contact sport? I don't think that's a great idea. I'm just, again, the chances are, I'm not saying Sally could hit her head and possibly be better in 3 weeks, okay? But she stands a higher risk of having a very prolonged recovery. And Sally's at what stage? And now she's missing school. So, how many is much? Too much? 3, what have you? Sometimes 1 is enough if it took too long to recover from that. And then you look at the past. Sally's already had 4 concussions in the playground, and we want her to start, playing ice hockey or what have you. Maybe not a great idea. Maybe Sally should go into swimming. And then the family history of concussions. Again, I think there's some anatomy issues there. So, Sally's dad had 5 concussions. Sally's older brother had 4 concussions. Sally's older sister had 3 concussions. She might be okay, but it raises my red flags. And then if Sally has a learning disability, or Sally has attention deficit disorder, and she wants to start playing a contact sport, not saying she can't, but if she gets injured, it's going to be a difficult road to recovery, because it's going to look a bit like she always has a concussion, and it's going to be very hard as a clinician to follow her and know when it's going to get better, and it's going to make her feel like her attention deficit disorder or learning disability is even much worse than what she had. So with that, we'll call it a day. So Kevin, yeah? Oh, he was looming over like the Grim Reaper. That was great.
You stay right here. First of all, I was quite surprised that he's not a doctor. That kind of shocked me. I've introduced him twice as Dr. Delaney. I apologize. Thank you again for the practical information that you gave the coaches and the parents especially. And you brought something forward that in 6 years of doing this, I didn't know or didn't notice that Blaine Hashisaki does have a big head. And I didn't ever really notice that before. Just before we take a quick break, I'm going to ask Dr. Cantu to come up. I'll give you about 10 minutes of questions. If you have any questions for either one of these gentlemen, if you mind coming up to one of the mics. Maybe we can turn down the lights just a tiny bit so we can see the mics. Does anybody have any questions they want to ask these gentlemen? Doesn't look like you answered all the questions, or these people aren't awake yet. Up. Yes, over there.
George Curtis, Toronto District School Board. Thank you. This question is for Dr. Cantu. I know that one of your co-authors in one of your books, Mark Hyman, writes about the U.S.'s obsession with youth sports and the rising costs of youth sports. My question is an equity question with respects to concussion. In your findings, are there a correlation between the length of recovery from concussions, and youths and socioeconomic status? And if so, as educators, how can we address that?
That's a great question. Before I answer it, I'm just thinking to myself, holy Christ, if Scott wasn't a friend of Blaine's, what would this be like? I'm not aware of data that correlates the duration of period of time out with concussions as with socioeconomic status. But that socioeconomic status is something that is a real issue. And I think we're going to see it change a little bit in the demographics, at least in our country, of who's playing tackle football a little bit. That all having been said, in that book that I mentioned about boxing, one of the chapters was written by a Harvard PhD who grew up in the inner city of Chicago, and he made it very clear in his chapter and discussions with me, the safest place he was as a kid, he felt, was in the ring with a trainer who was his surrogate father that he didn't have at home. And what he most feared was walking away from the gym on the streets to get back home. So we're banging heads isn't a good thing, but sometimes there are things that are even worse.
No, I'm good. A question on this side?
I'm Jeff Upton from Lakehead District School Board, Thunder Bay. People from Dryden actually come to us for a warm vacation. I'm just saying. just saying. Question is really simple. Can you share your concussion contracts with us? Because I think those are very useful for us, for our schools and communities to have.
Yeah, absolutely. Absolutely. I guess I go through Warren, I guess, would be the... Yeah, put it up on the web. Absolutely. They're made to be used. I still have to translate them into French. I know one person I'm not going to ask to help me translate. Yeah, no, absolutely. It's made to, and again, so there's the university one where there's athletic trainers are available, but there's a recreational for the athletes and for the coaches. So there's, and one of the reasons, not to get too long a story, was there was a lawsuit at Bishop's University which was settled, where the big crux of it was like the player was telling the coach apparently that he was concussed, and the allegation was that the coach was saying, just suck it up, get back in. And nobody medical was involved. So that was one of the impetuses. But there's a university, but more for what you guys need, there's a recreational where the parents have to sign it and the recreational coach has to sign it. And in terms of signs and symptoms, Yank, it would be my pleasure. Yeah.
Thanks, Scott. That's great. Thank you. Appreciate that. And one question on this side?
Hi, Stuart Monroe, an athletic therapist from St. John, New Brunswick. Just curious as to your thoughts of the years of research going into the helmets in football and kind of trying to change the culture of leading tackles without your heads, and now the new helmets come out that have the crumple zone on the front of the helmets. So just curious as to your thoughts on that.
I think I should be asking Blaine to come forward. As I indicated before, I'm 100% behind better helmets, and I think helmets are better today than they've been in the past, and I think they can even be better in the future. But until there's some way of anchoring the helmet on shoulder pad, flak jacket to prevent movement of the head, which obviously hasn't been done yet because you can't play with a helmet that's stuck on your shoulder pads. The forces are so great. It's a change in velocity of head that produces the strains in the brain, and so it's just not the answer. And it's also probably not the answer to do something external on a helmet that would have allowed two heads to stick together better. The tangential blows slide off each other because the surface is elliptical and very slippery.
Blaine, did you want to talk about the crumple zone? I'll tell you that, as Bob was saying, it sounds crazy, but there have been helmets that have been designed that have an airbag that goes off to immobilize your neck. So a bit like an airbag in a car accident that sort of would prevent your neck. The problem was once it went off, the helmet was done, and you kept having to go through it. But I'll let Blaine address that.
Thank you, Mr. Scott. There's been a lot of talk, of course, and certainly with the NFL, that there's a lot of effort and attempt to improve the performance of the helmets. And of course, there has been marginal improvement in exactly what Dr. Cantu said, and that is it's a minimal effect. There's so much energy in these impacts that to suggest that the benefits or the advancement we've made in helmets, and of course you want to make the helmet safer, but you can only make it so much safer. And it's marginal, and all these things that are touted and marketed are really marginal in terms of preventing or even mitigating the risk. We're getting better, the helmets are getting, no question, but with the impacts that we're allowing in the game today, they just can't manage them.
Seeing no other question, I want to thank these three doctors for being here today, and thank you for the input that they gave us, Blaine. And it's phenomenal that we get to host doctors of this caliber here in Niagara. So it's always exciting each year to see who we do have and the information they bring and the changes that are happening in concussion. So I really appreciate the information that the two of you gave today, and Blaine, thank you for your input as well. We're going to take about a 15-minute break, then we're coming back for a keynote speaker, our final speaker of the summit, which will be Haley Wickenheiser. So you do not want to miss her. So take about 15 minutes, grab a bite to eat and a coffee, and come on back in.